Welcome to a multimedia presentation made possible through a grant from the Michael Smith Foundation for Health Research. This presentation involves the use of sound. I suggest you use this time to adjust your computer's sound settings. If you need to, please feel free to pause the presentation, and when you are ready, you can advance to the next slide. Dr. Lisa Holsey completed her Bachelor of Science in Rehabilitation Medicine in 1985. She was trained in both physiotherapy and occupational therapy. Dr. Holsey worked clinically as an occupational therapist for almost 20 years in the neonatal intensive care unit. She completed her PhD in interdisciplinary studies in 2004. The goals of Dr. Lisa Holsey's research program are to 1. Understand the effects of the environment, such as painful or stressful procedures, on preterm infant development. 2. To develop accurate assessments with which to evaluate the impact of these procedures. And 3. To find the most effective ways to reduce the negative effects of the environment on the developing neonate. I now introduce to you Dr. Lisa Holsey.
Accurate pain assessment in preterm infants in the neonatal intensive care unit is complex. Preterm infants undergo repeatedly painful diagnostic and therapeutic procedures to ensure their survival. Preterm infants are at greater risk for enhanced pain sensitivity than full-term infants. Because they have lower tactile thresholds, pain signals become diffuse in their spinal cords, leading to overexcitability, and they do not have fully developed pain inhibitory systems. Therefore, in order to provide appropriate pain management in this population, accurate assessment of pain is necessary. Measuring pain in infants is complex because we are limited to indirect measures of pain responses. For example, older children and adults can tell us when they're in pain, but for infants we must rely on indirect measures such as behavioral and physiological indices. In addition, no changes in behavior or physiology are specific to pain. Measuring pain is also complicated in preterm infants because those born at earlier gestational ages may display different pain behaviors than infants born at later gestational ages due to neurological immaturity. A number of scales are already available for use in the NICU. The most popular add behavioral and physiological responses together. However, adding scores from these separate indices is problematic because in many infants their behavioral responses are not the same as their physiological responses. For example, when given sweet solutions to reduce pain, infants may stop crying and appear calm, but their heart rates can remain very high. So using scales which add these indices together doesn't allow us to know which system is affected by our interventions. Reducing behavioral responses without reducing physiological responses can leave these babies at higher risk for ongoing instability. The Behavioral Indicators of Infant Pain, or the BIP scale, is a valid, reliable, and accurate tool for measuring acute procedural pain in infants in the NICU. Combining the relatively most specific, developmentally relevant, anatomically based, and theoretically derived indicators, this scale offers significant advantages over others which are currently available. The BIP is a unidimensional scale that combines the most specific, individual behavioral indicators for assessing acute pain in this population, and it allows both researchers and clinicians to evaluate behavioral and physiological responses separately. The BIP combines sleep-wake states, 5 facial actions, and 2 hand actions. Unlike facial responses, hand and other body movements can be heightened in preterm infants who have had greater exposure to painful procedures or when handling is clustered together. We have added 2 clearly defined developmentally relevant hand actions, finger splay and fisting, which are derived from theory and which we have shown to be clinically reliable indicators of stress in this population. As mentioned in the last slide, the BIP scale includes sleep-wake states, 5 facial actions, and 2 hand actions to measure infant pain. The sleep-wake states are coded according to the definitions provided in the Newborn Individualized Developmental Care and Assessment Program, or the NIDCAP. The 5 facial actions are coded according to the definitions for the Neonatal Facial Coding System, and the 2 hand actions are coded according to the NIDCAP definitions. As you can see from this table, there are several sleep-wake states that can be measured. Please feel free to pause this presentation and read over each sleep-wake state on your own. There are 5 facial actions that can be measured, and this picture demonstrates each facial action, and 2 distinct hand actions. This picture demonstrates the 2 hand actions. Again, for review, we have taken pain-related indicators which have been validated individually for assessing acute pain in infants and combined them into a single scale which we have shown to be reliable and valid for assessing acute pain in preterm infants. Importantly, the 2 hand actions we've included seem to act as a counterbalance for assessing pain in infants whose facial responses may be diminished as a result of being exposed to repeated painful or stressful procedures. If you want more detailed information, you can see references on the BIP in Holste and Grunow, 2007, Pain, Volume 132, pages 264 to 272, or Holste and colleagues in 2008 in the Clinical Journal of Pain, Volume 24, pages 83 to 88. In conclusion, measuring pain in preterm infants is necessary for appropriate pain management. The BIP improves the accuracy of pain assessment for preterm infants by combining theoretically derived, developmentally relevant hand movements and sleep-wake states with anatomically derived facial actions, and most importantly, allows measurement of behavioral and physiological indices separately.
That concludes the lecture part of this presentation. If you would like to reach Dr. Holste, you can email her at lholste@cw.bc.ca.